Secondary pulmonary hypertension. Secondary pulmonary hypertension is defined as sustained elevation of the mean pulmonary artery pressure, PAP, to MORE 25 mmHg at rest or 30 mmHg on exercise, with an identified cause. Etiology and pathophysiology. Causes of secondary pulmonary hypertension are shown in Table 39. Clinical presentation. Ankle edema. Dyspnea may be associated with the underlying primary condition. The primary condition. Physical signs. These include signs of the primary condition, including cyanosis if present, and then of pulmonary hypertension, right ventricular hypertrophy, dilatation, and failure. Left parasternal heave. Loud P2. Elevated JVP with prominent V wave. Pansystolic murmur of tricuspid regurgitation. Pulsatile liver. Ankle edema. Investigations. The following investigations are used to confirm pulmonary hypertension, determine prognosis, and guide therapy. Echocardiography. Demonstration of dilated and/or hypertrophied right heart, Fig 84. Measurement of PAP. Exclusion of shunts and valvular and left ventricular abnormalities. A transesophageal study may be necessary to distinguish an atrial septal defect. ECG. Look for Fig 85. Tall P waves. Right axis deviation. Right ventricular hypertrophy. Chest radiograph. Look for prominent pulmonary arteries with peripheral pruning, and for features of underlying lung disease, Fig 86. Cardiac catheterization. Measures pressures and saturations, prognosis and shunt calculation, and assesses response to acute vasodilators such as prostacyclin, adenosine, or inhaled nitric oxide. Investigations to exclude secondary causes. Blood, FBC, for secondary polycythemia, liver function tests, erythrocyte sedimentation rate, rheumatoid factor, and autoantibody screen, and consider an HIV test. Pulmonary function tests, to exclude obstructive or restrictive lung disease. Sleep study, if there is suspicion of obstructive sleep apnea. Exclusion of pulmonary thromboembolism by ventilation perfusion scan, spiral CT scan of the chest with contrast, or pulmonary angiography, Fig 87. NB. Consider the following in your differential diagnosis. Secondary pulmonary hypertension. Left ventricular outflow tract obstruction. Ischemic heart disease. Differential diagnosis. Consider left ventricular dysfunction and primary pulmonary hypertension. Treatment. General. Optimize treatment of the underlying condition. Diuretics. Calcium channel blockers. Consideration of prostacyclin therapy, bosentan, and phosphodiesterase type 5 inhibitors. Lung or heart-lung transplantation. Specific. Shunts. Consider defect closure or pulmonary artery banding, some protection of pulmonary vasculature against high right-sided flow, if the pulmonary hypertension is not already too severe. Chronic obstructive pulmonary disease. Long-term oxygen therapy benefits selected patients with chronic obstructive pulmonary disease. Thromboembolism. Anticoagulation and consider inferior vena cava filter or pulmonary thromboendarterectomy. Ventilatory disorders. Consider nocturnal continuous positive airway pressure or nasal positive pressure ventilation. Prognosis. The prognosis is related to the underlying condition and the severity of the pulmonary hypertension. The 5-year survival rate of chronic obstructive pulmonary disease with edema is 30%.